It's Friday the 6th of June and this is the Hot Topics podcast. Welcome to the Hot Topics podcast from NB Medical. Neal Tucker here as usual. Great to have you back along for the ride, looking at some of the latest research relevant to us in primary care. Today we've got three great papers, one from the New England Journal of Medicine. You may have seen this in the mainstream media this week on the effects of exercise on colorectal cancer recurrence. We'll have a little look at that. We've got a great paper in the BJGP qualitative research looking at opinions from patients and GPs about the role of amitriptyline for managing refractory IBS. And then we'll round up with a paper in the BMJ published yesterday on dapagliflozin and its effect on non-alcoholic fatty liver disease, or MASLD as it's now known. A quick note on what's going on in the world of NB Medical. So actually that first paper on exercise segues nicely into saying our new lifestyle medicine course happened just this morning. Well, could be any morning. I don't know when you're listening to this, but it happened on Friday the 6th of June. So if you missed the live version of that, don't worry. You'll be able to catch up with that on demand through the nbmedical.com website at your convenience. Tomorrow, so Saturday the 7th of June, I'll be helping run our latest Hot Topics course. That'll be a live webinar. Again, I have no idea when you're listening to this, so it may not be tomorrow for you, but do check out the website. And I can't remember if I mentioned this on the last podcast, but we are starting to do face-to-face courses again. So come September, on Friday the 26th and Saturday the 27th, we'll be running a Hot Topics course in London. So close to Marylebone, Oxford Street. You can come and get some CPD and then go do some shopping, catch a show, meet up with some friends, get some dinner. Remember all those extra fun things you used to do after a face-to-face course. Check out the website for more details and to book on to those. I really hope it's a big success. If the demand is there, then we're going to start rolling this out around the country again, which would be absolutely fantastic. It's so great when we do face-to-face courses. We still get commissioned by lots of ICBs and health boards around the UK to do these for people. But it'd be great if we could start doing those for people where they're not being commissioned. But if you can't make that, don't worry. Don't forget to check out NB Plus as well, our subscription service, where you can get access to all of the courses that we do online and much more besides. Okay, on to the research, and we'll start off with the New England Journal of Medicine. So this paper is titled Structured Exercise After Adjuvant Chemotherapy for Colon Cancer. And I guess on the one hand, that sounds like it could be a pretty specialized piece of research. But given the fact that we're becoming so intrinsic in the management of post-cancer care for our patients, I think this is really relevant to all of us in general practice as well. So bit of background first. Colorectal cancer, third most common cancer, second biggest killer worldwide. If you have stage 3 or a high risk stage 2 disease, post-surgery, then you'll be offered some chemo, but despite treatment, recurrence still occurs in somewhere between 20 to 40% of patients. So that doesn't sound particularly great to me. We've got data showing that exercise can help prevent cancer. If you've ever been on our cancer course, you know we'll have talked about that in more detail. But we've also got animal studies suggesting that exercise can reduce the growth of established cancers. Plus, we've got some observational data suggesting that patients who increase recreational activity after treatment for cancer have a lower risk of cancer recurrence and death. Why would exercise help? Well, there's various possible mechanisms. Modulation of metabolic growth factors is thought to be high on the list. Also, reduction in inflammation and improvements in immune function. So this trial aimed to quantify that potential benefit. So this was an international study recruiting patients from a number of countries who had stage 3 or a high-risk stage 2 colorectal cancer, specifically adenocarcinoma. So that means that those patients either had growth of the tumour through the wall of the bowel or some local lymph node spread. And then they had to have completed adjuvant chemotherapy in the past 2 to 6 months. They didn't want patients who were already doing lots of exercise, so they were recruiting people who were doing less than 150 minutes per week of moderate to vigorous intensity exercise. Then participants were randomized to either a health education group where they had the usual kind of advice on exercise and diet and so forth, plus ongoing surveillance, or the exercise group. And in this group, they had further educational material, particularly on exercise this time, support from a physical activity consultant. I'm not sure why, but that kind of conjures images of an army major kind of shouting at you and then whacking you with a stick if you don't do enough press-ups. I'm sure that wasn't what they did. And then they had to attend a number of mandatory sessions. So 12 behavioral support sessions. So behavioral support trying to change people's behavior to increase their regular exercise. And they did that every 2 weeks for the first 6 months. And then they also did 12 supervised exercise sessions during that time. And then they also had 12 recommended supervised exercise sessions, but ones that weren't obligatory to go to. Then in the second 6 months, they had 12 further mandatory sessions of both behavioral support and supervised exercise. And then for years 2 and 3, there was a further 24 behavioral support sessions. So quite a lot of support for this group, but a far cry from one where the intervention is actually taking them to the gym 3 or 4 times a week. The goal was to increase their aerobic exercise by 10 METs per week from the patient's baseline. So what on earth is a MET? I would put a link to the Wikipedia page on METs for you if you want to know about this in more detail. It will do a better job of explaining it than I can, certainly in the time we've got available. But basically, a MET stands for Metabolic Equivalent of Task. It's an objective measure of the ratio of the rate at which a person expends energy relative to the mass of that individual. And the idea is that it allows you to quantify or to grade different levels of activity or exercise, so cleaning the house or going for a jog. And it's commonly reported as MET hours per week. Just to give you a few examples, walking slowly has a MET of 2, tennis doubles has a MET of 5, jogging at a medium pace, so 9 kilometers an hour. That may not be my medium, I have to say. I'm not very good at running. That's almost 9. Sexual activity, age 22, according to Wikipedia, has a MET of 5.8. So I'm not sure if that goes up or down as you get older and unfitter. Answers on a postcard, but that's a question for a different podcast, probably. The researchers wanted people to do activity with a MET of at least 4, but the good news is that's not too hard to do. So to get that intensity of exercise, you need to do brisk walking that's going to get you a little bit out of breath. That's enough for the study. That's enough potentially to see some benefits in cancer outcomes. And you only need to do that for 2.5 hours a week. Want to do more? That's fine. The participants could do more, but that was the minimum target that they were trying to achieve. So they recruited almost 900 patients across 55 sites, mostly in Canada and Australia. The median age was 61. Just over half were female. 90% had stage 3 colorectal cancer. And they were already doing a baseline level of 11.5 METs per hour per week of exercise. Adherence to the intervention in the exercise group was pretty decent, actually. So 83% attended the mandatory behavioral support groups. 79% made all those mandatory exercise groups in that first year. The take-up rate for the extra sessions was pretty poor at 20%. Clearly, people have felt like they'd generally had enough. And then the adherence did drop in the second and third years, but not as much as you might think. So down to about 2/3. So after all of this effort from the researchers and the participants, did it prevent recurrence of cancer? Well, yes, it certainly did. It reduced the risk. So 5-year survival was just over 80% in the exercise group and just under 74% in the health education group, giving an absolute risk reduction of 6.4%. Or around a 30% risk reduction in the chance of having recurrence, a new primary cancer, or death. Survival rates started to diverge at around 1 year post-intervention, and then they continued to separate further over the next 4 years and even further over the next 10 years. As the paper points out, this survival improvement is what you would expect to see from many currently approved drug therapies. So to get this from simply doing some regular, not particularly intensive exercise is genuinely very impressive. Interestingly, the exercise didn't result in weight loss or a reduction in waist circumference. So that's not likely to explain the benefits, rather the effects on those metabolic growth factors that's likely to be key here. So things like insulin and insulin growth factor. The authors didn't look at whether those participants who did even more activity had greater gains for cancer outcomes, although existing data looking at non-cancer outcomes, particularly relating to METs, shows that the benefit curve flattens pretty quickly with increasing levels of exercise. So the greatest gains are in going from doing basically nothing to doing something, rather than those people who might step up to running a marathon instead of doing a 5K run 2 or 3 times a week. In conclusion, this is convincing data that regular, moderate intensity exercise improves prognosis of colorectal cancer, and is certainly something that we should be discussing with our patients in that situation. I think the word exercise can make activity seem out of reach for many of the population, for many of our patients. But I think actually if we rebrand it, rephrase it, just say, if you can do a brisk walk for 45 minutes, 3 or 4 times a week, one that's going to get you slightly out of breath, that's much easier for people. That seems much more achievable, both physically and from the time constraints of day-to-day life. And it's also easily scalable. So as they get a bit fitter, as they're doing more exercise, you can just go slightly faster. So you can just maintain getting a bit out of breath. And I think that's a very easy message for patients to understand as well. Ideally, all our patients would get that behavioural support that they received in the trial, but obviously that's never going to happen. The good news, though, is that even the control group increased their activity levels. So we shouldn't be put off by starting this conversation, even by just having that chat. That could help change behaviour, and that could be the thing that ultimately saves that person's life. Okay, on to our second paper. This is in the BJGP, and this edition of the BJGP is all about celebrating qualitative research, something that is particularly important for primary care and almost always absent in most of the other major journals. As the various editorials this month point out in the journal, it's not just about having a chat. There is science and theory that underpins good qualitative research. We're going to actually revisit a piece of research I talked about a couple of years ago on the podcast that you may well remember. So that was the data that showed low-dose amitriptyline was useful for refractory IBS symptoms. This new piece of research then explores patients and GP views on amitriptyline prescribing for irritable bowel syndrome through qualitative interview studying, recruiting patients from that original Atlantis trial and GPs from the practices that were evolved in facilitating that. So the researchers conducted semi-structured telephone interviews with 42 patients at 6 months post randomization into that trial and 19 patients at 12 months, and they also interviewed 16 GPs. I think this paper is a good example to demonstrate how powerful qualitative research can be. So the authors identified key themes from the patients and the GPs, looking at the concerns around use of amitriptyline, but also perceived facilitators of acceptability and uptake, and then brought this together to highlight what might help us in day-to-day practice with aiding patients with those treatment decisions. For example, unsurprisingly, there were concerns about amitriptyline being an antidepressant. We hear this all the time when we're prescribing it, don't we? Almost part of my spiel is trying to undo that perception of it as an antidepressant. I'm actually sometimes surprised. I need to shut up more, because sometimes people are like, it's an antidepressant. Why did you tell me that? I was like, if I just hadn't mentioned that thing, this would be much, much easier. But lots of patients are worried about that. They're worried about the psychological effects that as an antidepressant might have on them, also accompanying social stigma. But they also identified that facilitators to uptake were things such as distinguishing amitriptyline for IBS from traditional antidepressant use, acknowledging that the dose is low that we're using in this context, and also emphasizing the ease and flexibility of use. And you may remember in the original trial with Atlantis, patients were allowed to self-titrate that dose depending on how their symptoms were. Another big issue was concern about the use of long-term medications in this context, particularly thinking about the development of greater levels of adverse events if people continue on it into older age. Also concerns about a desire not to medicalize IBS. To counter those concerns, they found knowledge of using amitriptyline for other conditions, including in the longer term, the recognition of the potential benefits beyond IBS as well. So not just adverse events, but some of those side effects could be a positive event. So maybe perhaps a person might describe them getting much better sleep when they're taking low-dose amitriptyline. That could be a benefit. They also highlighted an issue that I think is very common for us and for patients with many different conditions, and that's the desire for there to be something else to help. So we've tried the existing options and that hasn't made a difference. The patient's still got a problem. Is there anything else that could be of benefit? Amitriptyline in this context is still relatively infrequently used, so perhaps it does fill that gap for something else, another option for us and for patients. And of course, now we've got the data to support that, because the Atlantis trial showed that it is a highly effective option for many. The authors conclude, patients and GPs felt that the potential benefits of trying low-dose amitriptyline for IBS outweighed their concerns. When offering low-dose amitriptyline in this context, GPs could address patient concerns about taking an antidepressant for IBS, highlighting the low and flexible dosage and the other potential benefits of amitriptyline, such as improved sleep. I think this is a really useful piece of research. I think it's really helpful to show us what patient concerns are likely to be if we're maybe offering amitriptyline for refractory irritable bowel syndrome. I think it helps show us how we can allay those concerns, not to try and push amitriptyline on people, but as part of that shared conversation about how we can help with their troubling symptoms and ultimately improve their quality of life. Finally, onto our research published in the BMJ just 2 days ago. That's 2 days ago if you're listening to this on Friday the 6th. Otherwise, it could be any length of time. You may be listening to this in 2073 and you're a historical researcher looking at the moment that we decided it's better to put SGLT2 inhibitors in the drinking water, subsequently leading to worldwide catastrophic loss of fish stocks due to excessive genitourinary infections. Anyway, bringing it back to the real world and the present day, this paper is all about using dapagliflozin to treat metabolic dysfunction-associated steatohepatitis, or MASH. So MASH is the rebranding of NASH, which is the next step up the ladder from MASLD, which was formerly known as NAFLD, non-alcoholic fatty liver disease. Are you with me? If not, don't worry. Check out the blog I wrote on this about a year or so ago. I'll put the link to that in the podcast description as well. What's all the worry about? Well, there's been a big increase in liver disease over the last 30 years in the UK, a 400% increase and almost a doubling of deaths from liver disease over that time as well. Now, a lot of that is still linked to alcohol, but some of that is also down to MASLD, metabolic dysfunction associated steatotic liver disease. Now, when you look at it, the proportion of people dying from MASLD seems quite low, around 5%. But you do have to wonder if its contribution is significantly under-recognised due to this rather arbitrary distinction, or a historical distinction really now, of whether you drink alcohol or you don't. The reality is that many people will have a fatty liver due to metabolic issues, and they drink some booze, but previously they would have been categorized as having alcoholic liver disease, failing to recognize that that metabolic dysfunction has also had a part to play. Regardless, the paper says 5% of adults have MASH, so metabolic associated steatohepatitis. That's where you start getting inflammation in the liver as a result of the fatty deposition. And more than 30% of those who have obesity or type 2 diabetes will have MASH. Given the fact that both of these are on the rise, we're going to have huge increases in liver morbidity and mortality going forwards over the next few decades. Just to throw some further statistics at you, apparently, again according to the paper, up to a quarter of people that have MASH may progress onto cirrhosis. That sounds like pretty bad news to me. So, can SGLT2 inhibitors prevent this? Well, this paper shows that certainly dapagliflozin can. This has already been suggested in observational data, but this may be the first randomized controlled trial that's published in this area. This was conducted in China. It's a double-blind, randomized, placebo-controlled trial. It's not huge at just 154 patients or participants, but perhaps that's not a surprise because all of those participants needed to have a liver biopsy demonstrating MASH before inclusion into the trial, and then another one at 48 weeks. That's a pretty serious procedure. It's a serious intervention. It's time-consuming and expensive and associated with morbidity. Very large numbers in these trials would therefore be difficult. Participants could have type 2 diabetes, but they didn't need to, and then they were randomized to either dapagliflozin 10 milligrams or placebo for 48 weeks. And dapagliflozin came out on top. 53% in that group showed a reduction in steatohepatitis without a worsening of their fibrosis. That's always a concern when we're giving an intervention to reduce the underlying liver inflammation. And that compares to 30% on placebo. So that's a big difference. They also showed that there was resolution of MASH in 23% on dapagliflozin versus 8% on placebo. And very, very few significant adverse events. Only 1% of the participants, 1%. Doing the maths, that means it's slightly less than one human. That's presumably down to rounding, but that was 1% of participants on the SGLT2s had to stop due to adverse events. What does all this mean for our patients in UK general practice right now? Well, probably not much right now. How many of your patients can you think of with a diagnosis of steatohepatitis? It wouldn't surprise me if we see an increased drive to identify MASLD. National guidelines in the UK have been around for years suggesting those patients we should be looking into this in more detail and then how we can manage them if we identify NAFLD or MASLD as we now call it. The reality is that there hasn't really been that impetus in primary care to change practice and really push this as an issue. I wonder if that's because we feel that liver disease is just not as important as cancer, as heart disease, as respiratory illness and so forth. But with the rising incidence of liver disease, I expect that's going to change. Also, a lot of that drive is going to be down to the drug manufacturers themselves, so drug industry influence. And that sounds kind of negative, but it isn't necessarily meant to be. So if we've got a problem and then we've got a successful treatment, then actually it seems quite reasonable that we might want to use that treatment for that problem. But it's a slightly sad observation that pharmaceutical money influencing policymakers, influencing patient advocate groups may ultimately be what brings liver disease into the spotlight. It is long overdue that we take liver disease a bit more seriously. And this paper is a real positive, demonstrating, albeit with relatively small numbers of participants and in a Chinese population, but it shows that these conditions can be treated and improved with readily available medications. Now, of course, the SGLT2 inhibitors may have to fight it out with the GLP-1s in this arena, but coming out on the side of the SGLT2 inhibitors is that they are currently a quarter of the price per month of the GLP-1s. Ultimately, the money will decide. Watch this space. That's it from me today. Thanks so much once again for joining us on the Hot Topics podcast. You can always get in touch. Remember, you can email hottopics@nbmedical.com. You can find us on Twitter, on Facebook, or perhaps even social media platforms that are not run by American megalomaniac oligarchs. We'll be back in 4 weeks. Until then, take care. Bye-bye.